Hello and welcome. Thank you for joining me in this next talk of global LV function. And this is going to be a follow-up on my previous talk. So if you haven't watched that one, please watch it first, because in this one I will not explain any of those measures. I will not explain in detail how to do the measurements, how to do the objective measures of global LV function. I will put them into practice and I will try to train our eyes. I will try to give you a system of how to develop your skills of visual estimation. But again, in this talk, this is like a practical session, if you wish. The theory was covered in the previous talk on global LV systolic function. So watch that one first. All right. My name's András, and again, welcome to this talk. So these are the measures that I covered in my previous talk. So we were talking about fractional shortening. We talked about fractional area change. We talked about different methods of trying to give a numerical value to your ejection fraction. We talked about E-point septal separation. We talked about MAPC. And then we talked about some Doppler indices, mitral, annulus, S prime, MRDP dt. We haven't covered cardiac output and stroke volume yet. That's going to be the next talk when we're going to be talking about cardiac output and measurement of cardiac output. And then there's another one, which is a super complicated myocardial performance index. I only mention this in brackets just for completeness sake. Never use it. It's very complicated. All right, so these are your quantitative measures. Remember, I told you in my previous talk that you need to learn how to do these. You need to practice how to do these as many times as you can. And as you do that, slowly, you develop your skills how to use these quantitative measures in a semi-quantitative way so that you can do a qualitative assessment of that LV function. And qualitative means that we don't assign any numbers. We don't measure any numbers. In fact, we do see if the LV function is normal or mildly reduced, moderately or severely reduced if it's abnormal, or is it hyperdynamic. And in the ICU setting, very often this is more than enough. So we don't really need an actual number, and we don't always have time to measure out all those numbers. All right, so the next half an hour or so, I will show you tons of pictures, 50 or 60 different hearts, and then we'll go through all those measures, quantitative, semi-quantitative, and then qualitative assessment. I will start with a normal LV function, see how LVEF is there, 55 to 60%. So I'll let you watch each of these for a little while, and then on this first one, I will tell you all those measures that I was talking about in the previous talk. Again, it's like a summary or a revision of what we have done. So you find your long axis of the left ventricle, perpendicular to that, close to the mitral valve leaflet, you do your LV diameter measurement in systole and in diastole. So that gives you a good idea about LV size. But also, if you've done your measurements in systole and in diastole, you can plug that into the equation of fractional shortening. So basically that means that what's the difference between the systolic and the diastolic internal diameter length. And then with that, the machine can give you even an EF based on these one-dimensional measurements. The other things you can look at in 2 dimensions is in the short axis, you do an area of end diastole, you do an area of end systole, and this is going to be your fractional area change, which is a two-dimensional measure of your LV function. Ideally, you should be doing that at the mid-papillary level, but you know, this is when you look at the mitral valve level, that's as good as anything. Other things to look at when you do these measurements. So you look at how your mitral valve leaflet comes close to the septum. So that's your E point, septal separation. Is it coming very close to the septum? Yes, it is. Is it briefly even touching the septum? Probably. So that's all normal. So that means that's a normal systolic function. And then the other thing to look at is your mitral annulus, lateral mitral annulus, and the movement of that annulus in a longitudinal plane. So how much it's going up and down towards the apex. Is it moving more than about 1 centimeter, 10 millimeters? Yes, then again, it's highly likely that the LV systolic function is normal. And then after that, once you had a look at all these, not necessarily measuring them out, or no need to measure them at all, it's just you look at them, you put them away, file them away in your brain, and then you try to come up with an overall global assessment. Next, when you're trying to put it all together in terms of an ejection fraction, when you put your cursor or a point right in the middle of that cavity, you look at your myocardium. Is it thickening? Is it coming inwards? Is that cavity getting smaller in systole? Same over the short axis, even more obvious. You put a little dot in the middle somewhere, and then you watch how that cavity is getting smaller and bigger. You do it again in the apical 4-chamber view, and then you can ascertain that yes, those LV walls are thickening and they are coming in and out. The LV cavity is getting small and large. So that would be your visual estimation LVEF. So these are all the things that you can do with just 2D echo, and see how we aimed to do our best images. We optimize all these images. You try to do as many views. So you do a long axis, a short axis, an apical view. So in the ICU, I would always urge you to try your best to take as many pictures as you can and use as many of these sort of semi-quantitative measures as you can to come up with a good, quick visual estimation. And that's the basis of our visual estimation. So it is not a random number. You still have a lot of knowledge behind it. It is very much linked to your quantitative assessments that we just learned about in the previous video. And with all that, in the end, you come up with that normal systolic function, or you can say that by visual estimation, your EF is 55 to 60%. All right, moving on. The next one, still a normal looking LV. So these images are a bit less good quality because it happens all the time. In the ICU, quite often you don't get picture perfect images, and this is the case here. So you look at the same things that we looked at before. See how the endocardial definition is not as clear. I'm not even sure I can see the endocardium in all places. So there's a lot of dropout here and there. But still, this is when we mentioned that you might have to use a little bit your imagination. And then, we know that the endocardium is somewhere there. So you use your imagination, you use your intuition, and then still you can come up with a pretty good idea or a pretty good estimation of that LV systolic function. So we're looking at the fractional shortening, we're looking at the fractional area change, we're looking at the EF by visual estimation in all of them, we're looking at if you can, the E-point septal separation that doesn't show up very well here. And then you look at your MAPC, which is just right here. And then you can decide that this is a normal LV systolic, global LV systolic function with an EF by visual estimation, 55 to 60%. All right, let's move upwards first. So 60%, still in the normal range. Just imagine or remember, for a male 52 to 72% is normal, and for a female 54 to 74% for the EF. And look at all those measures. So see how again you can say that this is a normal looking LV systolic function. Your fractional area change is really pretty significant. So you see how the LV cavity is getting really very small when in systole. You put your little cursor right through the middle, and then you watch if those walls are coming in and out. Is that cavity getting smaller and bigger? See how yes, absolutely it does. E-point septal separation, mitral valve leaflet coming very close to that septum, so probably less than 7 millimeters, which is the normal range. MAPC, mitral annulus moving up and down, more than 1 centimeter. So if you look at the centimeter markings at the end, more than 1 centimeter, so that's normal as well. And the overall LV size, so see how again your centimeter markings are here. So you see that the overall LV size is about 5 point something, 5 centimeters. So that's normal. 5.2 for females, 5.8 for males is the upper end of normal. So all in all, you can say that your LV systolic function is normal and your LV systolic LV ejection fraction by visual estimation is about 60%. All right, moving up, 65 to 70%. So we getting close to the hyperdynamic range, not exactly, but almost there. See how the LV, overall the LV looks like it's working really hard. It is squeezing a lot. So put your little cursor right through the middle and then see how that cavity is getting very, very small on systole. There's a number of other things here. There's a flattened septum, but we will ignore all that right now. There's a small pericardial effusion. So we're just focusing on your LV function. And then again, have a look at all those things that we looked at before. See your mitral annulus, see your mitral leaflet. Have a look through that subcostal image. Again, same thing. You put your cursor in the middle and then see how those walls are nearly touching in the middle. So that is getting very close to the hyperdynamic range. And the LV actually looks, when you look at it, it looks like it is working hard. So the LV EF in this one was reported as 65 to 70%. So nearly in that hyperdynamic range. All right, let's move back to the normal range, 55%, bang normal. Just have a good look through. Same things what we looked at. E-point septal separation, MAPC, fractional shortening, fractional area change, EF by visual estimation in all these views. And see how in this one I can show you how the MAPC is different from TAPC. So TAPC is a right ventricular measure, and see the right ventricle is a bit different from the left, that the main movement is longitudinal in the right ventricle. So the right ventricular annular plane, the tricuspid annular plane is moving up and down a lot more than your mitral annular plane. So this one is less, but that's the normal looking heart, because the LV is working more in the circumferential and the torsion planes as well, and the longitudinal is just one bit of that whole geometry. So all in all, you can say that the LV systolic function is normal and the LVEF is 55% by visual estimation. All right, so again, lots of abnormalities, a huge dilated left atrium, there's mitral valve abnormalities, and in this one I'd like to point out that because of those mitral valve abnormalities, we can't really use our measures related to the mitral valve. So see how these mitral valve leaflets, they look very thickened and they fixed. So this one is probably a stenotic mitral valve. It's not moving much at all, not getting close to the septum, but since there is some mitral valve abnormalities, thickened leaflets and calcified leaflets, and posterior calcification as well, you can't really use these measures very well. So we rely on all the other things that we did. So we're doing our fractional shortening, we're doing our fractional area change, we can still do our EF by visual estimation, and all in all, it's just mildly abnormal. So 50%, again, I'd like to stress it or remind you that the normal EF is 52%, the lower end of normal is 52% for a male and 54% for a female. So that's your normal. So 50% is mildly reduced. It's already mildly reduced. Okay. We're moving. Oh, that one's not playing. We're going back and forwards. Okay, now playing. So going down, inching our way down slowly. So this one is 40 to 45%. We have a zoomed in image. We don't really have the apex here, but we still have enough information. We have a subcostal image. See how there is a big difference compared to the previous ones. Short axis image here and your parasternal long. So overall, this is a mildly reduced global LV systolic function. The LVEF by visual estimation would be about 40 to 45%. All right, 35%. Just watch it for a little while. Try to identify all those things that we talked about. Would you agree with that 35%? I think it's a very reasonable number to give. Again, looking at your mitral valve leaf, let's see how it's not very close to that septum anymore. Yep. This MAPC is probably a normal number. If we were to do the MAPC, I think it's gonna be about 1 centimeter or so. And quite often that's the case. So when you do 3 or 4 or 5 different measurements, sometimes one is a bit out of range. So one may be normal and the other is abnormal. And that's fine, and it happens all the time in real life. It's just you just have to put it all together into the big picture and then make up your mind once you've made all your measurements at the end. That's why it's important to have as many images as you can and as many measurements as you can. So all in all, we have a moderately reduced LV systolic function, which is fine for your ICU reporting. Or if you want to say LVEF by visual estimation is 35%. Okay. Ooh, we're going down and down, 25 to 30%. Again, I'll let you watch it for a little while. Some of the other abnormalities, this LV size is getting in the dilated territory. There's a pacing wire in the right ventricle, but again, we're just focusing on the LV right now. And watch that mitral valve, miles away from the septum. Doesn't go very close to the septum at all. When you look at that fractional shortening, so I think you see how that's really not normal. And then let's put our little cross in the middle and then see how the walls are coming in. So this is the mitral level again. Ideally, you should be doing this on your mid-pap muscle, but still, it's a good piece of information. And all in all, LVEF 25 to 30. So this is getting into the severely reduced territory. All right, go back and forwards. Yes, they're all playing. Again, another one with 25 to 30%. We have more information here. We have our parasternal long. We have our parasternal short. We have an apical 4, and this is your LV focused apical 4 chamber. And we have an apical 2 chamber view as well. So lots of information on this one. Try to do the exact same things that we've been doing so far. So LV is severely reduced. LV systolic function is severely reduced. And see how compared to that, the RV function looks much better. So the RV function is much better compared to the LV functions. All in all, LVEF by visual estimation, 25 to 30%. Okay, we're going further down, 15%. Again, lots of other abnormalities. There's a pericardial effusion here, but we're gonna ignore that today, and we're only focusing on that LV. Overall, systolic function is very poor, very severely reduced. So it's severely reduced LV global systolic function. That's your report. LVEF by visual estimation is 15%. And again, see how the mitral valve is very, very far from the septum. The mitral annulus is not moving much at all. See, this MAPC is very abnormal. So I can tell you that this MAPC is very abnormal. Fractional area change here, fractional shortening here. They're all very, very abnormal. So all in all, severely reduced LV function with an LVEF of 15% by visual estimation. All right, so after this, I'm gonna go through a few random LV functions. So jumping up and down, not in order. So this one is 35%. Watch it for a little while. Try to identify as many factors as you can. Some other things we can see here, hugely dilated RV and RV dysfunction. But again, we're only trying to focus on the LV this time. So LV global function is about 35%, moderately reduced. Next one, 45 to 50. Compare it with the previous one. This is almost normal, so mildly reduced LV systolic function. So as you train your eyes, as you develop these skills, I think I mentioned in the previous one, in some papers I see 150 cases that you have to do, others say 250, sometimes they even say 500 cases, that you've done 500 cases on yourself. After that you get very good at it. So I guess probably it's somewhere in the middle, but definitely in the hundreds. So you really should be doing 100 to 200, let's say 200 cases. Have a good look at them, report them, compare them to other studies, and then with that you slowly develop your skills. So this is a mildly reduced LV systolic function. All right, what about that one? Somewhat foreshortened is the image. So remember I talked about that foreshortening when the LV is and the heart is becoming globular instead of a pointy one. And see how the LV apex is kind of thickening inwards. It shouldn't do that. So it should stay kind of thin. So it should be pointy and thin. So this is telling you that this image is foreshortened. We tend to overestimate that LV function when the image is foreshortened for obvious reasons, because the actual cavity we're looking at is smaller. So that's why, and the systolic function looks better when you look at those foreshortened images by visual estimation. But then altogether, when you look your parasternal long axis, and that's a sort of a two-chamber view or something similar, and then that's apical 4. So you'll see that we can still report this as a 65% normal systolic function, getting close to a hyperdynamic. Okay, and then the next thing to think about is if you see regional wall motion abnormalities, like in this case. So I'll point it out to you. So the inferolateral wall is heavily akinetic. So you have an akinetic inferolateral wall, and that's fine. So you might see regional wall motion abnormalities in various locations when you try to report an LV function by visual estimation. You just note it, but the global LV function in this case is nearly normal. See how it's only mildly reduced. So try to just focus on the whole LV, the global LV function. And altogether, again, if you put your little cursor in the middle, see how those walls are actually coming in pretty nicely. Same here in the short axis, in that pap muscle level, and in your parasternal long axis. So yes, the global function is 50%, mildly reduced, nearly normal, to be honest, with some heavy regional abnormalities. Okay, going back to normal, 60 to 65%. Very nice images, very clear endocardial borders here, as you see. And again, have a look how the normal physiology and normal heart function. TAPC is very, it's moving up and down longitudinally a lot. So that's your tricuspid plane. Compared to that, the mitral annulus is numerically is a lower number, smaller movement in that longitudinal plane, and that's normal. All in all, your LV systolic function is 60 to 65%. Okay. Have a look at this one. Again, a normal one, 55 to 60%. Same things we're looking at. Now that we zoomed in, you can see how that measurement of the diastolic and systolic relate to each other. So that would be your fractional shortening. And your fractional area change. Currently, we don't really have much else. We can look at that mitral valve. We can look at that mitral annulus even there. All right, next one. Again, less good quality images. Tachycardic patient. This is more like what you're gonna get in the ICU setting. moderately reduced function. See how those, even though you can't really see the endocardial border clearly, especially here, still you can kind of see how you can say that it's at least a moderately reduced LV systolic function there as well. So LVEF would be about 30 to 35. Okay, another one, 30 to 35. Better images, better endocardial definition. Look at that mitral valve, look at that EF by visual estimation, 30 to 35%. Jumping up to a normal one, again, lots of abnormalities, especially the mitral valve, so we're gonna not use that mitral valve. They had some surgery on that one. So we'll just have a look at that visual estimation. We'll use the fractional shortening. We'll use the fractional area change. And that's a normal 55%. All right. Let's jump down a little bit. This one is a moderately reduced, 30 to 35%. Watch closely. Moderately reduced, and then mildly reduced, again we have a bit of a bobbing heart in a pericardial effusion, but again we're not gonna spend time on that. Just focus on your EF, focus on your LV function, how that LV coming in and out, LV walls coming in and out, cavity getting smaller and bigger. So all in all, 40 to 45%. Mildly reduced. All right, so that's a hyperdynamic one. So this one is 75%. And look how the cavity is getting obliterated very much in systole. So that's 75% in those short axis images. All right, again, lots of abnormalities, pericardial effusion, hugely dilated right ventricle, but we're focusing on that LV. You can see the flattened septum as well here, but again, just look at the LV, look at what's happening with the LV. So this was small cavity compared to the RV. However, the LV function actually was only reported for 45 to 50, so that's only a mildly reduced LV systolic function. This patient was very sick, you might imagine, with right heart failure. And then when they got worse, look at how compared to the RV, so RV is huge and it's very, very much severely reduced in function. But again, we're focusing on our LV. And this one was reported even in the normal range. So the LV EF is 55%. And that's when it doesn't really matter much in the ICU world how much your LV EF is, because this patient was in shock from right heart failure. So the LVEF and the number itself doesn't matter. It doesn't say anything, doesn't add any information. If anything, it's misleading. So we try not to use it. All right, one subcostal, one apical 4, mildly reduced 40 to 45%. Let's watch it for a little while. And now we're gonna start a little quiz. So I will tell you the number, so I'll let you watch it for a little while. I'll let you decide on a number, or is it, all I want you to do is to decide whether it's normal, or is it hyperdynamic, or is it abnormal? And if it's abnormal, is it mildly reduced, moderately reduced, or severely reduced? So that's all we need. If you want, you can try to assign an LVEF by visual estimation as well. So we're going to have a few of these to finish. I'll show you quite a few, and then I'll always wait a bit. I'll let you decide, and I'll tell you what I think. So this one is a dilated LV. The left ventricle global function is severely reduced. I would say 15 to 20% LVEF. And you see, again, we're looking at how that mitral leaflet is not coming close to the septum. The fractional shortening is clearly abnormal. The fractional area change is clearly abnormal. When we look at those EF by visual estimation, that's very abnormal. Look at that MAPC. That might be actually normal just by looking at it, but that's the odd one out. So all in all, severely reduced LV systolic function. Next one. I'll wait a bit. You decide. Try to think of a number as well, LVEF. So in this case, the actual LVEF might be 20 to 25%. So this is still a severely reduced LV function. And see how stiff those LV walls look. So this is a restrictive cardiomyopathy with amyloidosis. See how the mitral annulus is not moving at all up and down. So there's hardly any movement of that MAPC when you look at it. See how that mitral leaflet is not coming any close to that septum. So all in all, severely reduced LV function. All right, so this one's an interesting one. So we'll get through, this is one patient across about 2 weeks' time. So this was her first echo in ED when she came in. She comes in with a very severe community-acquired pneumonia, comes into ED. And then she comes up to ICU, and we have to intubate her. And she was intubated in the ICU for about 5 or 6 days. So that's her second echo in the ICU. And then she recovered, she survived, she went to the ward. And then once she was on the ward, she was having like a follow-up scan. So that's number 3. So all in all, so this is in the space about, in about 2 weeks' time. So from start to finish, her getting in and getting sick all the way to the third echo. So that's about a 2-week time span. Same patient, same heart. And see how there is a big difference. So the first one, so try to decide on your own, is this heart looking normal? See how tachycardic the patient is. She's pretty sick. She's not intubated here yet. So what do you think about this LV function? I think it's not normal, but it's not severely reduced either. So we thought this was a mildly reduced LV function, about 40 to 45% EF, mildly reduced. And then when she gets intubated in the ICU, that's echo number 2, see how the LV function is a lot worse. So this is a case of a septic cardiomyopathy. So you see how her parasternal long axis and the apical 4-chamber image. You put your cursor in the middle and then you try to decide, is this a normal heart? Definitely not. Is this only mildly reduced? No, I think it's worse than that. So we said that this was a severely reduced LV function, 25%. So she needed some inotropic support as well as a lot of vasopressors. At some point she needed 80% oxygen. So she was very sick, but then recovered and then went to the ward. And this is her follow-up scan. See how the LV looks so much happier. just compare these two, so these two and the fractional shortenings between the two. So see how no need to measure anything, no need to measure anything, and you can still see how very different these two fractional shortenings are here. So this LV function is normal here. So this one was reported 55 to 60%. Interesting case, septic cardiomyopathy, how much your heart can change in 2 weeks. Okay, next one. Watch it for a little while and I'll let you decide. Not the best quality image, but that's all good. Happens all the time in ICU. So I would say this one is more on the hyperdynamic side, 65%. Next one. I'll let you watch it for a little while. Dilated LV. And there's an LV thrombus here, if you watch carefully. But let's ignore that for the moment. I just want to know the global LV function. Qualitatively, severely reduced. Oh yes, definitely yes. So this is very clear. So it's not much more than 10% LVEF. So this man needed inotropic support as well. Okay, next one. Big abnormality is a huge clot in transit. But again, ignore that. Think about your LV, only your LV. What do you think about this EF? Hyperdynamic. So this is when we say that the LV cavity looks very small. And see how those LV walls are touching, nearly touching in the middle. So this LVEF would be what? 75, 80%. So this is clearly very hyperdynamic. See how the mitral valve is touching that septum for a while. So it stays there for a while. So it's a struggling heart still due to the RV failure. But the LV itself is empty looking, and the LVEF is 75-80% hyperdynamic. Okay, next one. We're going to ignore all the other abnormalities that we can see. So we have a huge right heart, we have a calcified mitral valve. So we can't really use those mitral valve related indices. So heavily calcified mitral valve, can't use MAPC, can't use EPSS. So let's do just a visual estimation. Do your fractional shortening here. Do your fractional area change here. Do your visual estimation. So what do you think? I think it's nearly normal, to be honest. Somewhere around 50% EF. And this patient is in big trouble with all the other abnormalities, but the LVEF in isolation is nearly normal, and the whole heart is just very abnormal around it. Okay, next one. Let you watch it a little while. Think about LV size, LV function, all those things that we looked at. Severely reduced LV function, LVEF 15% to 20% at best. Okay, next. Watch it a little while, watch the mitral valve, see that cavity. What do you think? This is a normal LV function. This is LV function of normal. EF by visual estimation would be 60%. What do you think about this one? So this is the odd one out. There's no organized cardiac activity at all. So this LV is clearly not moving at all. So this is a rest echo where there's no LV activity at all. Next one. Let you watch it a little while. Be methodical. Try to use all those numbers and all those methods that we described. And then in the end, we can come up with an estimation. So this is almost normal. I don't say it's completely normal, but nearly normal. So I would say it's a mildly reduced LV function, 45 to 50. Okay, next one. Make it a bit snappier. So this is clearly very abnormal. Heavily dilated, globular looking like a big sphere, this LV is. LVEF is very low, 10% maybe, 15. So severely reduced LV function. All right, so what's on this image? Just think back to the previous talk. So this is how we do our Simpson's biplane, so modified Simpson's biplane, the disk summation method. So see how those 20 little disks are allocated into that area there. So we do an apical 4-chamber image, an end diastole and then systole, and then we do an apical 2-chamber image, end diastole and end systole, and then the machine will work it out for us, and it gave us an LVEF by EF by biplane 65%. So that's a normal LV function, Simpson's biplane. Okay. Oops, I'll go back and forwards. Yes, they're all playing. What do you think about this one? Looks pretty good. I would think this is a normal heart, 55%. Next one. A bit less than the previous. Just watch it for a little while. This one's not normal, but I'd say it's only mildly reduced, 45 to 50. What are we looking at here? The one measure that you can use from this one. So if you identify your E point and how close it comes to that septum. So you can use your E point septal separation. That's one thing. You can do that fractional shortening. So that's your systolic and that's your diastolic cavity size. So you can use fractional shortening. You can use E point septal separation there. Okay. What do you think about that one? I would say this is normal, 55%. What are we looking at here? Again, M-mode image through the mitral valve. E-point septal separation. See how close that mitral valve comes here. So that's normal. All right, so that's your training the eye session. So in summary, I would urge you to learn as many of these quantitative measures as you can. Try to learn them how to do it. Try to learn them, try to practice them as many times as you can. And then while you're doing it, you can already start using them in a semi-quantitative fashion. Always do your best to have your best image quality ever, and then just keep scanning, do a lot of scans, and then with time and with many cases you will develop your skills and you will become a pro in this whole echo business. So thank you for watching, and I'll be back soon with other LV talks about regional function as well as cardiac output measurement. So thanks for watching. Bye bye.